restrooms are right outside this door. If you could put your phones on silent or vibrate if you haven't already, that would be wonderful. Is this anybody's first time, like, well, you have done an orientation though, right? Yeah. Anybody else who hasn't had an orientation yet? Okay, great. If you would like, when we're done, we're happy to give you a tour, give you some additional information about the community. So we'll do that. So I just wanted to take a moment to introduce Dr. Tseng. He is Associate Clinical Professor, Division of Surgical Oncology at City of Hope Medical Center in Duarte and City of Hope in South Pasadena, correct?
Yes.
Okay. Dr. Tseng pursued his medical studies at Northwestern University, followed by a residency in general surgery at UC San Francisco, and a fellowship in surgical oncology at the University of Texas and the Anderson Cancer Center. Prior to joining City of Hope, he was Associate Professor of Surgery at USC, where he led the retroperitoneal sarcoma surgery program. So I hope take a moment and just we welcome him and thank you for coming. All right.
Okay, well, thank you for that wonderful introduction. And before I get started, I just wanted to say that you guys have a wonderful facility here. It's very beautiful, and I actually live not too far away from here. And my family, my son, we go to the Tacos Ensenada. That's just right across the street. It's it's Taco Tuesday, in fact. So they have good deals on tacos. So. Yeah, so I'm going to get started. My colleague, Dr. Cranmer, is on the way, and he'll also be giving a talk as well. So I have some introductory slides about sarcoma, and then also some slides that are focused more on surgery for sarcoma. That's what what I do as a surgeon. So we'll get started. Let me make sure this moves forward. It seems to be, oh, there we go. Okay, good. And you guys can all hear me okay? Okay, good. So first of all, these are my disclosures. And another disclosure is I am on social media. Feel free to follow me if any of you have an account. And then this is my other disclosure, and that is that I am a surgeon. And so this is what I do day in, day out. So I will talk a little bit about radiation therapy and medical oncology, but those are, to be fair, those are not my areas of expertise, but they're very important parts of the treatment of sarcoma. So cancer, just to start off, so cancer it refers to crab, the fleshy appearance of crab. And I should give Gary Larson credit for this. This is Gary Larson, The Far Side comic strip. It was something that I certainly grew up with and I loved. And so these are different kinds of crabs, or some of the more common crabs. So today, for the next hour, we're going to be talking about a rare crab, and that is sarcoma. So what is sarcoma? So sarcoma literally means cancer of the flesh. And we think of sarcoma, medically, we think of sarcoma as bone sarcomas and soft tissue sarcomas. Bone sarcomas arise from the bone. Some of the types of bone sarcoma that we know about are called osteosarcoma, chondrosarcoma, Ewing sarcoma. And then there's soft tissue sarcomas. Bone sarcomas are primarily in children and adults, whereas soft tissue sarcomas are in children and adolescents, whereas soft tissue sarcomas are mostly in adults. The focus of these slides, my slides, are going to be on soft tissue sarcoma. And so what is soft tissue sarcoma? So the one concept that I wanted to get across is that these are cancers, plural. They're all cancers, but there's more than one type of sarcoma. And in this case, these cancers arise in the soft or connective tissues. So those are things like fat, muscle, vessels, fibrous tissues. And so although they may involve organs in the body and they may spread to organs, they do not per se arise from the organs in the same way that we think of things like breast cancer or colon cancer. So they arise from the soft tissues, but again, they're plural. They're more than one type of cancer. Overall, as a group, they're very rare. They're 1% of all cancers in adults, and that accounts for about 15,000 cases per year in the United States. That's not a lot. That's not a lot. I mean, it sounds like a small city or a small town, but compared to breast cancer, the breast cancer has over 250, 300,000 cases per year.
Is that new cases?
Yes, this is referring to new diagnoses. It's a good question. Yeah, and feel free to ask questions along the way. Yes,
Breast?
that's in the United States. Yes. So what causes soft tissue sarcoma? And generally speaking, it's unknown. There are certain genetic or hereditary syndromes where there is a genetic predisposition to developing cancers. And among those cancers, patients that can develop sarcoma, but there's generally it's unknown. And then to put things in perspective with the more common cancers, this is not related, sarcomas are not related to things like smoking or diet or obesity. We think of smoking leading to lung cancer, but that is not the case for sarcoma. There's no, except for there are rare exceptions with certain types of pesticides and things like that, but those are very much a rarity. For the most part, we don't know what causes soft tissue sarcoma. So what that means is it can affect anyone. I'd say that's a scary way to look at it, but it is true. It can affect anybody without any connection or association to gender, race, or socioeconomic status. And where does soft tissue sarcoma develop? It can develop anywhere in the body, and it's not organ specific. It's so as opposed to breast cancer or colon cancer, which is specific to an organ, soft tissue sarcoma can develop from fat, for example, and fat is anywhere in the body. In terms of numbers, the most common location for soft tissue sarcoma are the extremities or the limbs, but also in the abdomen and generally any other parts of the body. But just based purely on the numbers, over 60% of them are in the extremity. This gives you an example of soft tissue sarcoma. I apologize if this is too much, but these are examples of soft tissue sarcoma, different parts of the body. And you can see in the center, you can get breast sarcoma. In this case, this is angiosarcoma, but is not arising from the breast tissue itself, per se. So this slide, so don't focus too much on the details, but this is just showing the complexity of soft tissue sarcomas, which, as I said in a previous slide, it is more than one cancer. In fact, the WHO, the World Health Organization, recognizes over 50 to 70. Sometimes the number goes up to 100. It's at least 70 to up to 100 different subtypes of soft tissue sarcoma. And keep in mind, again, this is all 1% of cancers in adults. So I like to use this analogy, and I've used this with patients that I see in clinic, with trainees that I teach, and that is that sarcoma is a little like wine. And I hope that's okay for those of you who are wine connoisseurs, because I am not one myself. But the analogy is that there are many different kinds of sarcoma, many different histologic types and subtypes, and the subtleties and the complexities of each type are very important to someone who treats sarcoma, who sees sarcoma, to a sarcoma patient. Just like wine and the different subtleties and the nuances are very important to a wine connoisseur. And so you can get different kinds of sarcoma, like liposarcoma, like undifferentiated pleomorphic sarcoma, like Lyle-Mile sarcoma. The names all have sarcoma in them, and like lipo is fat, just like liposuction. Lyle-Mile is smooth muscle, but they're all different kinds of sarcoma, and they're all important to recognize the differences in the subtleties between them. I also wanted to kind of caution or bring attention that there are some sarcomas that do not have the word sarcoma in it. So there is a malignant peripheral nerve sheath tumor, which can be very aggressive, and the name itself doesn't say sarcoma. It sounds like it's just a tumor, but it is in fact a sarcoma. We're in our field, we're also recognizing the genetic or molecular changes in that are inherent and important to some of these sarcomas, and so sometimes they're being named by the molecular changes. So this is, I believe this is pronounced a Chick-Dux4 tumor. Is that?
Yeah.
Oh, okay, one vote in the audience, yeah. Good. So these are, again, names of different types of sarcomas. I don't need to pay too much attention to them. This is different clinical behaviors, different clinical features of the sarcomas, and you can see it's very individualized. And that's my point about understanding each specific sarcoma type or subtype, and knowing that, for example, some never spread. Some spread only or predominantly to the central nervous system, to the brain. Lymph nodes, kind of further down on the bottom right there. So the majority of sarcomas do not spread to the lymph nodes. So again, different from breast cancer, from colon cancer, even prostate cancer. There are a few exceptions as shown here, but the majority of them do not involve lymph nodes. So in terms of diagnosis, just like any other cancer, X-rays or imaging and tumor tissue or pathology. For soft tissue sarcoma, the majority of the X-rays that are useful for us as clinicians are CT and MRI. That is with contrast, unless there's a reason not to get the contrast, but it's different. So for example, if you get a sports MRI, like for a knee injury, that's usually without contrast. But for sarcoma, if you have a sarcoma of the knee, it's much more helpful to have contrast. Occasionally ultrasound, occasionally PET scan, but by far CT and MRI. And then tumor tissue is probably the most important thing. That's how you really know what sarcoma you're dealing with what the type or subtype it is. And most of the time, this is obtained by needle biopsy. Occasionally, we do surgical biopsies where a patient goes under anesthesia and we take a portion of the tumor for a sample of the tissue surgically. Treatment is centered around these three things, just like other cancers: surgery, chemotherapy, radiation therapy. And the point of this is that it is very much a team effort. It involves surgical oncology, medical oncology, radiation oncology, not necessarily in that order. It just depends on the situation, the individual case. But also very important to us in sarcoma are the radiologists and the pathologists, and especially the pathologists that have expertise in sarcoma, specifically in sarcoma. That's a picture. It's off of Google, so it's not, just full disclosures, it's not our City of Hope one, but that is what a tumor board can look like. And when you hear that word tumor board, what it is it's a conference, it's a gathering of in this case, the sarcoma physicians on campus to discuss individual patient cases. And then I'll kind of come towards the end of my slides here about outcomes are better with the sarcoma specialist. These are multiple studies that have demonstrated this. This is perhaps the largest study from France with 35,000, almost 38,000 patients, in which patients who see a sarcoma specialist have better outcomes, better overall survival compared to those who do not. And I think that's intuitive. It's a very rare disease. It's a very complex disease. I don't get into the complexities of the disease itself. But to see a specialist, it's just kind of like if your car is a special brand of a car that, is very unique, you want to go to a mechanic who has, thinking like a surgeon here, but you want to go to a mechanic who specializes in either the European car or the Japanese car or something like that. And so go see a sarcoma specialist. So these are my introductory slides. I have a few more slides about surgery. Are we okay on time to it's about another 10, 15 minutes? Yeah.
When you're in there and the different tissues, how can you tell a
Yeah.
difference? Let's say regular muscle tissue or
Yeah.
tissue.
It's a good question. Why don't we save it to the next section is actually going to be about surgery. And okay. So I'll move on then. It's about 10, 15 minutes. Okay. So sarcoma surgery, so this is the main form of treatment for localized disease. And that means when the disease, the tumor has not spread to other organs. What I wanted to emphasize is that for sarcoma surgery, certainly the technique of surgery is very important, meaning you can't be a sloppy surgeon. You have to have very good technique, in fact, just because of the complexity of the cases. But as you could see with the seesaw there, the biology of the disease, and that refers to an understanding of the disease, the expected behavior of that disease, in this case, sarcoma. That's very important, and in fact, it can be even more important than the technical aspects of the operation. That goes back to my wine analogy about knowing the exact histologic type and subtype. By the way, I keep on saying histologic, and histology refers to it's how the tissues look under the microscope, but you could ignore that word. It's basically saying type or subtype. These are examples of sarcoma surgery, and this is basically just saying that as a sarcoma surgeon, we operate everywhere. We go where the sarcoma goes. So this is different than, say, I keep on going back to breast cancer, but, breast cancer surgeon operates on the breast, whereas, and a colorectal surgeon operates on the colon and the rectum, the GI tract. So for me as a sarcoma surgeon specializing in sarcoma, I can sometimes operate on the breast if there's a breast sarcoma, or the colon if it's involved by the sarcoma. So we operate everywhere. We basically, as I said, we go where sarcoma goes. And then in terms of surgery, I like to think about it as extremity and trunk, trunk referring to the torso, and retroperitoneal. I realize I don't think I put in a word or a slide about, so retroperitoneal refers to, do I know? Oh, never mind. So sorry. So extremity and retroperitoneal. We'll get to retroperitoneal in a second. First of all, extremity. So extremity refers to the limbs, the arms and the legs. And this is an example of a patient I took care of several years ago. In fact, I think she's been to this facility before, but anyways, but at the time she was 24 years old. She's a writer. She had a right axillary or chest wall rhabdomyosarcoma. That's the MRI with the tumor. That's her shoulder there that you're looking at. And that's her tumor there in yellow. So orthopedics had recommended amputation. Yeah, because it's very involved into her, the blood vessels, the nerves in that area. Although her arm was functional, to be fair. Yeah, and so she didn't have any swelling, and her arm and hand were actually functional, even though this tumor was enwrapped by the blood vessels and the nerves in the area. And so we started off with chemotherapy. We gave the patient, we referred the patient to medical oncology. The medical oncologist agreed, and we gave chemotherapy. Neoadjuvant means before surgery. This is what after neoadjuvant chemotherapy, the tumor did shrink. It was still in close proximity and touching up against and entwined with the blood vessels and the nerves. But we spent, rather than do an amputation, which is, it's actually very quick and easy to do an amputation, but it takes much more time and effort to separate out all the nerves and blood vessels. And, this was a 6 or 8 hour operation. And so we salvaged her limb and got the tumor out completely. The patient went on to receive further chemotherapy and radiation therapy just because there are probably microscopic cells that are left along the vessels and the nerves. But we did that intentionally in an effort to save this 24-year-old's arm. And she's doing well, and she's now, I believe, 5 or 6 years out from this operation, and she's still a writer, and her arm's totally functional and disease-free. So anyways, sarcoma surgery for the extremity, in general, limb salvage is now standard of care. If this were 10 or maybe 20 years ago, if you had a sarcoma of the arm or the leg, the answer would be amputation. But now you still want to do the optimal cancer operation. You don't want to leave any cancer behind, like actual visible cancer. But we optimize the situation with radiation therapy and sometimes chemotherapy. And then function preservation is very important. Now, having said that, there are still situations where we do have to do amputation. So it's not that for every case, we can save the limb. So getting back to surgery, so that's extremity surgery for extremity sarcoma. So retroperitoneal, what that refers to is the back of the abdomen. So you think of retro, like retro going back, like going back in time, or retro. Peritoneal is the medical term for the abdomen. So this is the back of the abdomen. Just think where the kidneys are. So sarcomas can develop and can grow in the back of the abdomen. And this is what they look like. This is, again, I apologize about the picture, but they are very large tumors, and this extends. It occupies the entirety of the abdomen, and that's the yellow is the dimensions, and the colon is intertwined into that. Yeah. So retroperitoneum again refers to the back of the abdomen. That's where the kidneys are. The majority of the histologic types, again, the types of sarcoma that you see there are liposarcoma, and so they develop from. We think that they develop from fat, or we think that they originate from fat. And where is the fat in the body back there? It's typically in the back of the around the kidneys. So in all of us, in the human body, around the kidneys is normal fat, and we think that that's where these liposarcomas develop from. There are also leiomyosarcomas, about 10 to 20% of them, and they're clearly a different beast, as I like to call it. I like to call sarcoma beast. It's a different beast. These are again large tumors. This is I'd say my only claim to fame at this point. I'm not any, but I was featured in the New York Times, and there was a lot of publicity when I removed this tumor a few years ago. Yes. But sarcoma surgery, yeah, it's a great question, because and it's interesting to think about how the patients, the short answer is the human body in a way adapts to the presence of this large tumor. They're typically more slow growing. They can be fast growing, and they can certainly change and become fast growing and aggressive and spread. But in this situation, the patient the person adapts to it and just thinks that their abdomen's getting larger. And it doesn't cause any alarming symptoms. It doesn't really cause pain. It doesn't really, until it kind of gets to the tipping point where the patient says, I got to go get this checked out.
What about an annual blood panel? Most people get that with their insurance.
Yeah, it doesn't know. None of these come up in any blood test. Yeah.
That was a leiomyosarcoma?
That was a liposarcoma. Yeah. The leiomyosarcomas tend to be smaller. They're still large tumors, but they're not usually as large as this. So in the United States, standard resection is complete removal of the tumor, and then the abdomen is a limited space. So with the kidneys, with the colon there, removal of the tumors if they are involved. So half of the patients with these operations, these are complex operations. Half of the patients will lose the kidney on the side of their tumor, and a portion of the colon, also usually on the side of their tumor. But it can be much more, and really much more. These can be 10-hour, 12-hour operations because of just the complexity of the case, trying to save this organ or that organ, major blood vessels, vascular surgery involved. And then these are examples of cases. This was about a year or so time when I decided to take a lot of these pictures, but this is to emphasize the biology is still very important despite the technique. And this is also to show that this was at a different institution, but we at City of Hope are a very specialized program, and we probably see some of the highest volume of these rare diseases at City of Hope. So that is the conclusion of my slides on surgery. And I also wanted to wish everybody, July is Sarcoma Awareness Month. I think many of you may know that. I did without my tie, but the closest to yellow that I had was a yellow tie, which I didn't bring, unfortunately, but happy Sarcoma Awareness Month. And then Oh, well, there you go. There you go. There you go. Wonderful. That would be purple is the color for, yes. Yes, I see it. I see it. So this is just the summary and key points, rare disease, many different types anywhere in the body. Treatment is very much a team effort. I refer to a specialist. So thank you. And I wanted to end with, this is our sarcoma team at City of Hope. I'm very honored, privileged to work with all of our team members. And when I say team members, all of these people shown here, including one sitting in the back right there, all of us specialize in sarcoma. So a large part of our practice, if not the majority of our practice, is dedicated to sarcoma. There are not a lot of centers, even academic centers, that can have such a dedicated team of physicians to this rare disease. Yes.
So I had
Yeah.
a comment and question.
Yeah.
First of all, when you talk about getting specialist care, I was at a different, in a different HMO, and then I came to City of Hope for like a third opinion, I think, and everything was so different because the City of Hope recognized the retroperitoneal component of that as well. And so I just encourage anybody who has any association with this, friends, family, yourselves, to get more opinions. And then secondly, City of Hope being wonderful. There's also another place in Santa Monica that I've had treatment called Sarcoma Oncology Center.
Mhm.
But I also think is really terrific, and they work with City of Hope. So just wanted to make that comment, everyone.
Yeah. Yeah. Thank you.
And second of all, I wanted to ask the question, I've been told that, what I had retroperitoneal liposarcoma has a tendency to live in the lungs.
Mhm.
And I wondered if you agree with that, and if you could say anything about the mechanism of that happening.
Yeah, well, it certainly can occur. It depends on the aggressiveness of the tumor and specifically the grade of the tumor. So, with liposarcoma, there are tumors that are entirely low grade that do not have the potential to spread, but then they certainly can have areas that develop high grade disease, which can have anywhere from a 10 to 30, 40% risk of spread, and typically to the lungs, just as you pointed out. Yeah. Yes.
Question. Is there any connection between lipomas and liposarcomas developing later on?
Yeah, it's a great question. As far as we know, no. So no. Yes. But if there is, but they can look very similar, especially the larger lipomas. Lipomas are benign, but the ones that are larger, and especially if they're growing in size, or occasionally if they're causing symptoms, but not necessarily. If it's larger in size, if it's growing in size, it's best to just have it looked at. Yeah. Yes.
Question is, you said there's no blood work that can be done to test it. Now, what about if anything get caused with one? How can you sense there is a problem in that area? How do you determine that? Is it only by like MRI and
Yeah,
and stuff? Say, oh yeah, there's tumor here
Yeah.
or whatever, or
Yeah, it can be subtle. It's so if you have a mass that certainly, if you can feel if you detect a mass yourself, if it's a fairly large size and it's, and especially if it's developed in a short period of time, not as opposed to you've had it for 10 years, and but if it's suspicious, I would have it checked out by your primary care doctor to start. There's a saying out there that if it's larger than a golf ball size, to have it checked out or have it examined. But I think that started from the UK, I believe, but anything larger than a golf ball size.
How do you you have different kinds of insurance, for instance, Kaiser, HMO, how do you get referred there? I mean, because, they really only want you to.
Oh, that's a good question. I don't have an answer for that, but sometimes you just have to, even I have patients I pay out of pocket for just a second opinion at least at the start.
End up paying out of pocket.
Not always, but it depends on each individual situation. And certainly City of Hope, we have a whole insurance financial team that can help you to work that out.
I was just gonna comment that I paid about $300 out of pocket for that opinion. Every penny was very well spent. And
That was just for the opinion, not.
just for the consultation. And then the financial department that Dr. Tseng is talking about, helped me quite a bit with finding ways to get insurance that cover treatment there.
Hey, do you know,
I did, no time.
that's fine.
So I wanted to say thank you, Dr. Tseng, for his
Yes.
presentation, and we want to bring up and introduce Dr. Cranmer as well. So thank you. This is just a little thank you.
Oh,
from
thank you.
us.
Thank you.
Yeah, and thank you for coming.
Yes, okay. Thank you.
So then this is Dr. Lee Cranmer. He's a professor and section chief of Sarcoma Medical Oncology and vice chair of the Department of Medical Oncology for City of Hope Cancer Center, Duarte. Dr. Cranmer attended medical school at UC San Diego, completed his residency in internal medicine at the Mayo Clinic in Rochester, Minnesota, and a fellowship in medical oncology at the University of Arizona Cancer Center in Tucson, where he spent 15 years treating sarcoma and skin cancer patients. Prior to joining City of Hope, he led the sarcoma program at the Fred Hutch Cancer Center in Seattle, Washington. So we welcome you. Thank you. And just to confirm, we are doing video, if that's okay. Just want to make sure that's okay with you. Okay. So welcome. Do you have a presentation we need to look? Okay.
I do.
Okay, you got it.
Right here. Thank you for the kind introduction. Wait, does it go in here or no? It doesn't go in there.
Try on
Oh, it's on this side.
And I'm just gonna make sure. There you go.
Okay, that's the one. This is
That's a little
a
quicker.
laser.
Yeah. We're not gonna see. You,
There I is.
there you is. And then audio looks good. Play from beginning.
Here we are.
Take it away, sir.
Okay. Well, thank you for that kind introduction. And so now that you've had the introductory course, now we're going to do an advanced course to follow on in medical oncology. And I'll touch on some of the issues that Dr. Tseng brought up and also discuss from the perspective of a medical oncologist, which I am. So I'm a doctor that wants to help patients with cancer and specifically with sarcomas, but my area of expertise is to use medicines to help my patients. But I also find that I often, with my patients, work with them to understand their conditions. Much sort of like the discussion we're having today is a common discussion that I'll have, and to make decisions about their care, which may or may not involve the use of medicines. There. So, starting with a little bit of history, the origin of the word sarcoma, it's from the Greek, sarcoma, meaning a fleshy excrescence or fleshy substance. And it was recognized as early as 1804 that it was a harmful tumor of the connective tissue, more or less malignant. The plural would be sarcomas or sarcomata if you want to use the Greek. And I don't really see the connection, but sarcasm apparently comes from the same root. In terms of the numbers, these are some numbers. These are from 2024. About 1% of patients with solid tumors in the United States, about, if you include gastrointestinal stromal tumors or GISTs, you're talking about 24,000 cases a year, and probably on the order of 10,000 people who die of the condition in the United States. So that gives an order of magnitude. If you are comparing it to breast cancer, which is in the hundreds of thousands, it's a smaller population. But as Dr. Tseng alluded to, there's great variety. My number is not 50 to 70. My number is 173 because I got a big textbook, and I counted up everything that was in our clinic, and there were 173 different histologic entities that we were responsible for in our clinic, including that maybe you didn't include the bone sarcomas,
will. There's variety in terms of how we classify them. So bone versus soft tissue is one classification that Dr. Tseng touched on, as well as some being on the trunk or the extremities versus retroperitoneal. That's a major division in the field. And now increasingly molecular classifications, where we're actually learning what's going on inside cells that are driving these processes forward. And we're discovering that we used to assign a single word to something like liposarcoma, and in fact, there's 13 or 14 different types of liposarcomas. But they all look the same if you're just looking at them or looking at them under the microscope, but they behave differently based on their biology, and the treatments we're developing depend on us understanding all these different types within something that we just give a single word to. Now, risk factors, there are some genetic syndromes that predispose to development of these. So one that comes to mind is something called Li-Fraumeni syndrome, which is a genetic syndrome that predisposes to a wide variety of unusual cancers, including sarcomas. There are some environmental factors, and this actually has an impact in my own clinic. Over the last 10 to 15 years, I've seen a fair number of veterans who had served in Southeast Asia and were exposed to herbicides. And they experienced sarcomas that at least the Veterans Administration attributes to their service in Southeast Asia. Patients who were treated with radiation as children and were cured of a cancer when they were children, but the exposure to the radiation predisposes them 20, 30, 40 years later to developing a sarcoma. But as Dr. Tseng alluded to, in most cases, we don't have a specific cause, but there are some sarcomas, some subtypes that are associated with certain syndromes. So people say, well, they're rare. Are they really that important? Well, I would make the argument that, in fact, they are. First of all, rare diseases, of which sarcomas are part of it, make up 20% of cancer. That's not rare. Major advances in cancer care for everyone have come from the study of rare diseases. For example, I used to do a lot of work in melanoma, and if you told me 15 years ago that the stuff we were working on in 2025 would be the standard first-line treatment for lung cancer, I would have told you that's crazy. Lo and behold, what we were working on in melanoma, which is not actually a very common disease, is now standard first-line treatment, not just for lung cancer, but for a whole variety of different types of cancer. Sarcomas affect a younger age population than many other types of cancer, and that magnifies their effect when someone is affected by these diseases, both directly because of the diseases, frankly, cause an increased number of years of potential life lost, but also sometimes we're trying to get rid of amputations, but still sometimes we're undertaking life-altering treatments to people, and it affects people dramatically. And most importantly, for those who are directly affected and their loved ones, these diseases are devastating. So to me, 4 major reasons why the fact that these are rare does not make them unimportant. Now, I'd like to just shift gears and talk in a little bit of detail because it's important, not just in the context of understanding sarcomas, but in terms of understanding how we talk about cancer generally. The concept of staging. People will say, what's my stage? And how do we arrive at that, and what is the purpose? Well, technically, the stage of someone is the extent of the disease at the time of their initial diagnosis. Now, someone might say, oh, well, I was stage 1, but then I was, or he was stage 1, but then he was found to be stage 4. Technically, that's not correct. Once you're stage 1, you're always stage 1, because the purpose of staging was to determine the efficacy of surgery. It's expanded to other treatments as well, but given a particular extent of the disease, how effective is surgery going to be? That was the original purpose of staging. And it remains a guide to selecting treatments, but it isn't an absolute property. Now, in arriving at the stage, there's different staging systems in different types of cancer. And there's a book, I wouldn't quite call it encyclopedic in size, but it's pretty big. I'm not even sure if they still print it. I know it's obviously available online. The AJCC, American Joint Commission on Cancer Staging booklet. And for most types of solid tumors, so we're not talking about leukemia, for most of them, they use 3 factors to arrive at a stage, and they call it T and M. So the primary tumor, often how large it is, or where it's located anatomically, the presence or absence of lymph nodes being involved, and M is metastasis, has the disease spread distantly from its site of origin. So if it started on the leg, is there disease present in the lungs now? In sarcomas, there's one other factor that's critical to staging, and that is something called the grade of the tumor. And that's a property arrived at or derived. We can sort of guess what a grade is based on the macroscopic behavior of a tumor. How fast is it growing, basically? But fundamentally, it's pathologists who will look under the microscope and determine the grade. And at least in sarcomas, we typically use 1, 2, and 3, low, intermediate, and high. But I've changed the size. Does this show in here? Well, I guess it doesn't. So grade is extremely important in telling us about the biology of the aggressiveness of a sarcoma. Indeed, it is the most important single factor in determining outcome or prognosticating outcome in a patient with sarcoma. What's the grade? Because it's telling us something about its fundamental biology. The T is generally the size of the tumor, and you want it as small as possible. And I made smaller because most sarcomas do not spread through the lymph nodes. There's some of those 173 subtypes that do have some predilection for lymph nodes, but most seem to spread directly through the blood. And finally, metastasis spread to a distant site from its site of origin. Yeah.
Grades change once you've got your diagnosis. Can you will they flop back and down?
Well, they can flop back or they can flop forth, but not back. So that's a great question. It's alluding to something that I think Dr. Tseng was mentioning with liposarcomas. Oftentimes you have what we call a well-differentiated liposarcoma, which has a low grade, and they can grow very slowly and can become enormous if you have enough time for the body to accommodate. But those cells are already abnormal, and they can change and begin growing much more quickly and become dedifferentiated, which is higher grade. And that represents a change in growth rate of between 10 and 20 times is the sort of order of magnitude of how much faster that higher grade tumor is going to be growing. Plus, in the case of liposarcomas, the disease is more likely to acquire the ability to metastasize. The low-grade tumors, especially in liposarcomas, almost none of them metastasize. They can cause problems nevertheless, but almost none of them truly metastasize. Now, just to give you an example of what our pathologists are going to be looking at, on the left is an example of a low-grade sarcoma. And you see these nice little swirlies here, and there's the blue things. The blue things are the nuclei. That's where the DNA is in the cell. And the pink stuff is we'll call it the body of the cell, or the cytoplasm. And you notice these little blue things, they sort of all look the same. They're very similar to one another. And again, you have these nice little swirly patterns. That's an example of a low-grade tumor. Over here, we have an example of a high-grade tumor. So notice the little blue things, they're different sizes. Some of them have little dots in them. There's no organization. It's sort of just smashed all over the place. This particular picture doesn't fully give the perfect picture, but there's a cell dividing there, so you can actually see cells that are dividing. That's an example of a high-grade tumor. That's what the pathologist is going to be looking for. And see, they're very different. This looks more similar to something that's normal, and this is definitely abnormal. And that's a reflection of the grade. And again, probably the single most important factor in determining outcome. And this shows that staging, when we use a 1 through 4 staging system, although there's sub flavors, but 1 through 4, the 5-year, how long, the likelihood of someone being alive at 5 years after diagnosis decreases with an increasing stage. Stage 1 is pretty much just low-grade tumors, generally intermediate or high-grade tumors in stage 2 to 3. And if it does metastasize, the grade really doesn't make quite as much a difference. But staging fundamentally is to tell you what's the likely outcome if we're primarily if we're using surgery as it was originally promulgated. Yeah. Well, lymph nodes. So remember, lymph nodes are part of the system. It's sort of considered an intermediate type of metastasis if it is in the same area. So for example, if you had a sarcoma or some type of cancer arising on the leg and you had lymph nodes involved here in the groin, that would be intermediate in prognosis. And generally, for most types of cancer, would be considered stage 3. Historically, in sarcomas, it was considered stage 4, but maybe a lesser type of stage 4. Stage 4 light, if you will. But typically these diseases don't spread through the lymphatics initially. Yeah.
Well-differentiated liposarcomas do not metastasize.
They do not typically metastasize. It's very uncommon. Indeed, there's even arguments as to whether or not we should assign in that particular condition the name of sarcoma to someone, because when you assign the name of sarcoma, you're saying that person had cancer. And that's a big deal. I think atypical lipomatous tumors is an alternate way of describing it, because it doesn't, it sort of is in a gray zone as to whether, is it true, has it really reached cancer? And it becomes sort of a semantic issue. Now, that being said, so going back here, people say, oh, I'm stage 4, we can't use surgery. Well, actually, I don't do surgery, but I'm a big fan of surgery. And I think Will's even accused me of being too aggressive a surgeon, because even with advanced disease, even with stage 4 disease, there are people that are effectively treated with surgery. And so here's a nice example where we have a CAT scan of someone's lung. You can see their heart here, and these are the lungs. Most of the white things are blood vessels, but there's a thing here. There's a thing that's a couple centimeters. That's a metastatic tumor. And surgery can be an effective treatment and cure people even when it has spread to the lungs. But there's certain conditions, and this is the results of a study that tried to say, well, why, how can someone be cured? What factors predict that? Well, first of all, the surgeon's got to remove everything. So that's what an R0 resection means. Everything's got to come out. A smaller and lesser number of tumors will make that more feasible. And after initial diagnosis, a longer period of time without disease. And that's telling you something about the biology. Remember that balance. There's the technique. The surgeon can pluck out all sorts of things, but ultimately biology is what is going to determine whether or not the surgeon is going to be successful. And so if someone has gone 5 years and then developed something in their lungs, a single tumor, that tells you something about the underlying biology of that disease. It doesn't like metastasizing, but it did, and therefore is likely to be more amenable to surgical treatment, even if it's metastatic. But quite often, people who have metastatic disease are not going to be amenable to treatment with surgery because their biology isn't the right biology. Now, one of the great pleasures of my career has been seeing the world change and new types of medicines being introduced. But before we talk about that, in terms of the types of medicines that we have generally, I put them generally into 3 categories. There's a few minor categories as well, but these are the major categories. So chemotherapy, chemo. So people say, oh, am I going to get chemo? Well, it depends what you mean by the word chemo. If chemo means medicine for cancer, then there's a lot of things that are chemo. To me, chemotherapy is something very, very, very specific. It is, and just in simple terms, it's an antibiotic for cancer. It's intended to kill the bad guys. Just like when one takes amoxicillin for pneumonia, you're trying to kill the bacteria that are causing the pneumonia. And indeed, many of our chemotherapies were developed in the search for antibiotics, and some of them turned out to not be very good antibiotics, but they were sure good at killing cancer cells. Second category is targeted therapy, and targeted therapy really came into its own about 2000. That was approximately when we began to have targeted therapies. And the concept there is, if you know what's causing the disease, you know what switches have been turned on inappropriately, maybe you can design a chemical that will go turn those switches off. And it turns out that works. It is better if you know exactly which switch is the right one, because if you don't know which one's the right one, you can just go try to switch off a bunch of them and hope it works. And that doesn't tend to work as well. But even when you do that, you can have a beneficial effect. But it's especially good when it's like a sniper rifle. When you know exactly that's the switch that's on, we're going to turn it off. It can be remarkably effective. And finally, major area where we were doing it in melanoma before it was popular is immunotherapy. And that's the concept of recruiting the immune system to attack the disease. And for many years, there were efforts where we were trying to make vaccines, because vaccines work so well for infectious diseases. Why can't we make vaccines for cancer? Well, there's a reason. It turns out that that's not the problem. That's not the reason that the immune system generally doesn't get rid of the cancer. Generally, the reason is the immune system's trying to get rid of the cancer, but the immune system's being turned off for several or a whole bunch of potential reasons. And it turns out over the years, over the past 15 to 20 years, we've identified some of the major mechanisms by which cancers will turn off the immune system to allow themselves to grow. And so again, you know what the problem is, you can develop a solution. Yes.
These examples you have, are they used for all different types of cancers?
Well, no, they aren't. Although I would say pembrolizumab, which goes by the trade name Keytruda,
What's that?
that's pembrolizumab. I'm sorry, it's the bottom one. It's an immunotherapy that has an enormous number of indications, because it turns out what it does to correct the immune system turns out to be a trick that many, many, many different types of cancer use. And again, we were studying that in melanoma originally, and now there's like 50 or 60 different indications in the FDA package insert for it. It keeps expanding. It's an enormous, you have to dig around to find the information you're looking for. There's so many reasons to use it. And so those are the three major categories of types of medical treatments we use. How are we doing on time?
We have, I mean, what?
Oh, okay. Okay, good. Now, this is one of my favorite slides, because this is sort of the history of what has happened in sarcomas. And first of all, I want you to notice several things. So this is a list of drugs, most of them which are approved drugs for use in sarcomas, and the year of introduction, and also what type they are. So if they're green, they're a chemotherapy, and if they're red, they're sort of a targeted therapy, and if they're purple, they're an immunotherapy. And what I would have you notice first of all is there weren't a lot of things approved for 30 years, and then all of a sudden it's accelerating. We're getting more things approved, and actually this list is incomplete at this point. There are more things that have been approved in this field. Another thing is I have these little parentheses, and I'm saying the giant cell tumor of bone, epithelioid sarcoma. So out of that 173 or however many different things that we're calling them, now we're getting treatments that are focused. Up here it was one size fits all, and that doesn't work well in clothing, and it turns out it doesn't work well in cancer treatment. So things are accelerating. We're getting new treatments targeted to specific diseases, yes.
Last one, the purple one, I can't see the year, but what is that for?
Amitriptyline autoleucel. So all of that word, those two words actually mean something. That is an immunotherapy for, I put synovial because if I put sarcoma, it wouldn't look so neat. Synovial sarcoma, that's a very specific type of sarcoma. And it turns out what we do is we take cells from some white blood cells from someone and we process them in the laboratory so that they can be reinfused and go attack the cancer. Yes.
That's,
Yeah, this is slightly a side topic, but so don't feel obligated to answer, but with the current government in Washington, the federal government, do you expect to continue to see this acceleration, or do you expect to see a deceleration?
So one thing that sometimes I've been asked is, are things being hidden? Frankly, for financial purposes. That somehow there are solutions to problems, but they are not being released because it's advantageous to someone. Right? First of all, the people I work with, because I've been involved in development of a variety of these agents, they're people too, and they have family members and loved ones who get cancer and die of it. Secondly, if we would just want to get away from anything and just say we're a pure economic argument, if someone has an effective treatment, a highly effective treatment for a cancer, there is such a tremendous economic motive to make sure it's out there that I don't see that stopping. There's a lot of turmoil right now, but I don't see people saying, oh, well, we're not going to do this anymore. It's so compelling. And even if you just want to look at it as, well, what does an investor think?
yeah, but
I don't
very,
think of
very
it.
costly for these newer therapies, right?
It is, but
How do you get
an
paid for it?
effective cancer therapy, though. I mean, there's nothing to me that I've seen more expensive than ineffective cancer treatments, where people who are productive members of society die and are disabled. So that's my 2 cents. But happy to talk about that offline more.
I would like to.
But again, this has been terribly gratifying. Nevertheless, okay, so who in this room knows who that is? If you can see behind this, raise your hand if you know who that is. Okay, most people do. Take a look. Okay, the majority of people do. So this is Gerald Ford, who was president when these two medicines were approved. And doxorubicin is, both of these drugs are still drugs that we are using. They're still important in treatment. And I'm sorry, that his face is covered. But when I'm giving a talk to my trainees, almost none of them know who that is. So why do we use medicines? There's several reasons, and there's some words that we were introduced to in Dr. Tseng's lecture, and I will repeat. So there's treatment in the vicinity of primary treatment. So someone has bump, we identified, oh, bad sarcoma, we got to do something about it. They're going to have surgery. Let's give them some medicine now. They're at high risk, even if Dr. Tseng does a fantastic job, high risk of this disease coming back. So we can give them treatment. Neoadjuvant treatment would be treatment prior to surgery. That might be intended to cause a tumor to shrink and maybe turn a tumor that was unremovable into one that's removable, like the example he brought up. It may also serve to decrease the risk of recurrence, because if it's going to recur, maybe it could recur at the site of where it started, but more often it recurs someplace else, like the lungs. So it might have an effect on that and might improve the cure rate. Or Maybe Dr. Tseng's already done his surgery and thought, well, this isn't going to be a big problem, but we discover, oh, wait, this is going to be a big problem, high risk of recurrence. So we might give treatment with medicines afterwards. It's obviously not going to improve the surgery because the surgery already happened, but it might decrease the risk of recurrence. And finally, if someone has disease that has spread in their body, or even if it hasn't spread, but it can't be removed and it's causing symptoms and growing, that may be a reason to use medicines. And that might help lengthen someone's lifespan. It may help control their symptoms and help them live better and longer. So those are reasons to potentially use these treatments. Now, the things that Dr. Tseng does in association with, for example, Dr. Amini and Dr. Sampath, our radiation oncologists, are highly effective treatments. Overall, and you can correct me if I'm being too optimistic, overall, for achieving a local cure, all comers, this is about 90% effective at achieving a local cure. Not so much in retroperitoneal sarcomas, but all comers. But why does it fail? Metastasis is the dominant reason. The disease at that point when Dr. Tseng is in the operating room, it is already spread. It's already in the lungs. We just can't detect it. And so that's where we think about using chemotherapy or medicines in the context around primary treatment. Now, there are a number of diseases which are prominent in children. So osteosarcoma, that's a sarcoma of the bones. Ewing sarcoma, which often arises in the bones. Rhabdomyosarcomas, which arise in the skeletal muscle. And these are diseases of children. And when we tried to treat them with surgery back in the 60s and 70s, the cure rate was 5, maybe 10%. They do the surgery, and with like osteosarcoma, standard treatment, cut off the lip. And then about 6 months later, the chest x-ray would show tumors in the lungs. And then we discovered, oh, well, if we're getting this chemotherapy stuff, remember that doxorubicin stuff I mentioned, that was coming online about then. Said, well, we can shrink these tumors, so maybe we can give the chemotherapy at the time that they have their initial treatment. And they started doing it, and it would shrink the tumors, and they could do better surgeries. But there was another thing they noticed. The kids weren't dying like they were supposed to. And that's because the chemotherapy might not be able to cure the disease when you can see it, but when it was microscopic, you could cure it. And in all three of these types of conditions, after work over the last 50 years, the current regimens have taken us from a 5 to 10% cure rate to a 50 to 75% cure rate. It's a huge, huge victory that people don't often appreciate. But the use of these medicines in other types of sarcomas is more controversial. This looks like a complicated diagram, but it summarizes a lot of information, and it's actually relatively simple to understand when you know what's there. So this is looking at a bunch of clinical trials that were done over the course of about 30 years at different institutions, where they were saying, okay, people high risk of, got a sarcoma, high risk, we're either going to give them chemotherapy or we're not. But some of them were quite small. Like there was one here, which was a total of 29 patients, which is not many for an experiment like this. Some of them were a bit larger, but overall there were about 1,600 patients in this summary. So they took all these different studies and they can glom them together statistically. And they weren't able to show that actually getting chemotherapy was better in terms of survival. It was sort of, they called it a trend. That means it's sort of on this side where chemotherapy is better, but it's not statistically different than no difference. But it seems to be getting in that direction. More recent data has suggested if you target to the people at the highest risk, then you actually can make a difference. And this is still being investigated and proven, but some people can't wait for us 10 years to prove it. We have to make a decision right now. But in this particular data analysis from Europe, blue was low risk, and chemotherapy in terms of survival didn't seem to make a difference. But if you were at high risk of recurrence, then getting chemotherapy, so this is the survival curve. So at time zero, 100% of the people are alive, and over time, people are dying from the disease. This is high risk, no chemotherapy, high risk chemotherapy. I'd rather be here. And so that does provide a justification and rationale for why we give chemotherapy in the primary setting. Harvey, what time is it now?
It is a little bit after 2.
Okay.
Like,
Just five more minutes. And actually, so what I'd like to just show are two, well, why don't we just do one? I was going to look at different examples of different types of treatment, but immunotherapy, because I think a lot of people have who has heard of immunotherapy of cancer? So almost everyone in the room in some way, shape, or form. You might not know the details, but you've heard about it. Well, I alluded to the fact that it was that the first place this really broke out was in melanoma. And melanoma arises in the skin, it has a lot of mutations. So biologically, it looks very different to your immune system. So it looks very distinct. And that's why the immune system can start going after melanoma. And there are cases where people spontaneously cured themselves of metastatic melanoma. It didn't happen very often, but it has actually been documented. But then we started expanding to other areas. Turns out lung cancer actually is a very similar problem to melanoma. People smoke for 50 years. They develop mutations in the cells that are in the linings of their lungs. Those cells look very different. They start growing, but they got to do something to evade the immune system. It turns out they use the same trick as in melanoma. Sarcoma's a little bit different. Most sarcomas don't look very different. They don't have lots of mutations because their mechanism that develops isn't really, for example, associated with smoking. So they're not associated with developing lots of mutations. And so initial efforts didn't really show a lot of activity, but this is one situation actually where they did use pembrolizumab and gave it to people with a whole bunch of different types of sarcomas. And they said, well, what's the change in their tumor sizes after we give it? Down is good, up is bad. And each color represents a different type of sarcoma. And what you see is there's a whole bunch of red ones down here. There's 4 of them out of 10. And those are what we call undifferentiated pleomorphic sarcomas. And they're getting smaller. Some of them are, at least in 2 patients that were treated, they disappeared entirely. So there are some people with sarcomas who respond, but not if you just give it to everyone. When we treat melanoma nowadays, yeah, we give immunotherapy to everyone, unless there's a really good reason not to give it. But in sarcomas, that doesn't really work. But there are subtypes that respond. And one of them turns out to be something called angiosarcoma. So this is a cancer of the blood vessels that develops. And it comes in several flavors. And I'm going to go here. So here, looking at on this side, focusing on this side, this is the same type of thing. Down is good, up is bad. And the different colors represent different types of diseases. Well, purple represents angiosarcoma, typically arising on the scalp or in the skin. But there's other types that arise like inside the body. So it turns out the type that arises in the skin is sort of like melanoma. It's sunlight causing damage and mutations, and that makes it look immunologically very different. And it turns out that type arising in the skin, which was a terrible, awful disease. You'd find that someone would have a little thing on their scalp, you'd try to cut it out, and it would immediately recur right outside that area, and it would keep doing it, and you just couldn't control it with surgery. But it turns out these immunotherapies can cause dramatic responses, including in some people it going away entirely. And I know that because my patient, now 14 years ago, who had metastatic angiosarcoma, it had spread all around his body, and he got this drug or pembrolizumab, and he's free of disease. That disease effectively is cured. And he was one of the first case reported. But this was a study trying to confirm it. You can see the sort of red stuff. And then it's going away and largely gone away. This is at 16 weeks. So that's an example where even though if you just throw these drugs at sarcomas, they don't necessarily work that well. If you find the right setting, they can. And another setting, this is an observation, a patient of mine, where we're still trying to confirm this, but I think it's something real. And so a disease, chondrosarcoma. So chondrosarcoma is sarcoma of the cartilage. And this is a bad disease. This doesn't respond to chemotherapy. It laughs at chemotherapy. And I had this guy, he was a real nice guy. He'd had a chondrosarcoma on his left leg. He'd actually had an amputation and it came back in his lungs. We're out here and it was sort of growing. And that was in January 2017. These sort of popcorny things, it looks like popcorn. And I said, well, we can't, and we tried to get him on trial, weren't able to do it. And I said, well, we can get you some of this. This was nivolumab, which works in a similar way to pembrolizumab as an immunotherapy drug. We could try this and see if it does anything. And we did, and we got a scan in March. And I said, oh, well, this doesn't look too good. I'd rather have this one than this one. So let's stop. It mustn't be working. And so we stopped. And in the meantime, we were trying to find an experimental treatment for him. And in June, or July, the research coordinator came up to me and said, "Well, he is just such the nicest guy. He really was the nicest guy. There's just one problem. He has no measurable disease." I said, "What are you talking about?" And I pulled this up, and it all went away. And what was happening here, in retrospect, was what we call pseudo-progression, meaning the immune system's attacking the disease, and trillions of cells are coming in and causing these tumors to get bigger. But then it all went away.
What inspired you to take another picture?
Well, I was trying to get him on a clinical trial.
So it was just luck that you took that July picture.
Well, we were going to get something. I mean, he was going to start if it was going at this pace, he was going to have symptoms real soon. That was the other thing. He didn't have any symptoms.
What I'm hearing all day long from both of you is that there aren't real good symptoms in the preliminary stages, but how do you, your metrics, how do you, except through pictures, really understand how to catch it at a point where you will feel more successful?
Well, that's a great question because that has to do with the concept of cancer screening. And cancer screening depends on, so yes, can you detect a form of cancer when it is treatable? And can you do it in a way that's not harmful?
CT scan?
Well, sometimes in lung cancer, I mean, when I heard they did the study and finally showed that getting for smokers who were at high risk, so you're choosing a high risk population, and you get a CT scan, I think when people are 55 or something like that, and that had a survival benefit because you could do something. You would find these diseases, and your surgeon can go and pluck it out, and that was effective. When in doubt, cut it out. Does turn out to be pretty good advice. And so that's an example where you focused an intervention on a high-risk population, so it's high yield. And the thing is, when we do that, you're gonna do some surgeries on people who it turns out not to be cancer. So that's the risk. Now, in the setting of sarcomas, these are not common enough for us to screen. So that therein lies the problem. So why do we diagnose people? They go, well, I see a fair number of people, they go to the emergency room, and you practically can't get out of an emergency room without getting a CAT scan nowadays. And it's found incidentally.
That's how mine was taught.
Yeah, found incidentally. Other ways, they develop symptoms. I thought I was getting fat. Well, you were getting fat, but not for the reason you thought.
If you had a wish to catch all of these early, would you suggest having an annual or an every other year sort of body scan just to see, or is that not reasonable? Because many of us were quite healthy.
They have tried that. It doesn't work. When we can see something on a scan, that's not early detection. Biologically, it's not early detection. According to stage, it may be, but biologically, if you can see it, that's biologically not early. You just think of cancer generally, something that's this big from when it started, something that big is 90% of the way to getting you. So ultimately, some type of blood test may be able to do this.
Doesn't City Hope have something where there's this little tiny something that's in the bloodstream that it's brand new? Okay,
We're trying, I'm sorry,
you know what I'm talking about.
well,
Blood
we're
markers.
trying to look at that. And also as a way to monitor people over time. I mean, I would love, for example, someone who was at high risk and they've had their surgery and we've given them their chemotherapy and done their radiation. What do we do right now? We get a bunch of scans. And frankly, we spend a huge sum of money on scans. People have a lot of confidence and they want the latest one. What am I getting my PET scan on? And I have to say, well, I'm not going to order a PET scan because it doesn't help. But we use scans right now. That's not early detection. To me, what I'm seeing finally are blood tests being developed, personalized blood tests that can actually detect the disease before we can actually see it on a scan. I think for following people over time, that's going to be useful. But I do think over the course of the next 20 years, blood tests that are able to screen, but a blood test is going to tell you, should you go look for trouble? And then we can go do whatever scan.
20
you want.
years is a long time.
Well,
I know, I'm sorry. We're working hard, but 20 years is a lot of time, but I've seen what's happened over the last one. It's phenomenal.
and with AI, payments and.
I see it accelerating. I don't see it decelerating. Well, I
One
think
last question.
I talked too long. Okay.
Okay, what's the name of the test? Is it?
Well, there are
available
there are a number of tests that look at cancer. One that I use, and I'm not affiliated with them, is Signatera.
CIGN.
CIGNATERRA.
What is that?
Well, it's a blood test that looks for circulating tumor DNA, because when you have a tumor, those cells are sick. And some of them just die and release their DNA and start circulating in your blood. And you can detect it, even at tiny levels.
Is that the French one? I just heard
I don't think so.
It's from New
No, je ne sais quoi. I didn't learn French in high school. I learned German, the language of planet.
Thank you. It's been wonderful. So generous with your time. Thank you so much. Really, thank you for being here.
Thanks, everyone. Oh, yeah, sure.
Would you use dogs to detect diseases?
Dogs?
No.
So now that's interesting in the context of sarcomas because it turns out there's